The next talk is on the management of hemophilia in perinatal settings. Unfortunately, we found out this morning that Dr. Victoria Price from Halifax will not be able to be with us to give this talk. But in her inimitable way, the chair of CODEROUGE and the organizing committee, Dr. Rochelle WINIKOFF, is going to give the talk about the management of hemophilia in perinatal settings. Rochelle?
A great physician, and I'm sorry that she couldn't be here with us today. Her conflict of interest is that she's a co-investigator in the CHIMP study, which looks at Canadian hemophilia management in the perinatal setting. As a background, the hemophilias, we all know, are X-linked disorders. Hemophilia A affects 1 in 4,000 live male births, hemophilia B 1 in 20,000 live male births. And newborns and women with hemophilia, so hemophilia carriers, are at increased risk of bleeding during the peripartum period. Management of patients with hemophilia and carriers of hemophilia require a multidisciplinary approach. It goes without saying that we need the input from OBGYN, anesthesia, neonatology, just to name some. But at the center and the core of care of these patients remains the patient and her family and the nurse coordinator, of course, of the multidisciplinary clinic in places that benefit from these aids. What are the issues that we're faced with when we're dealing with a woman that carries hemophilia and her pregnancy? First, we need to identify and not miss the fact that a patient is a carrier. We need to focus on the diagnosis of an affected fetus or a potentially affected fetus. And we need to deal with the risk of bleeding during pregnancy, labor, and delivery, and deal and prevent, ideally, the risk of bleeding in the affected neonate. So the objectives of the talk are to underline the importance of identification of hemophilia carriers and women and girls with hemophilia, discuss options for prenatal diagnosis, discuss the mode of delivery, indications for factor replacement in the baby, in the newborn, look at indications for neuroimaging in the newborn, and discuss some avenues of current research that are ongoing. So the number of carriers of hemophilia is increasing due to the number of obligate carriers. I will remind you that the incidence of hemophilia is probably stable. However, the longevity of hemophiliacs in current times is such that approaching a normal lifespan, as opposed to many years ago and decades ago where hemophiliacs did not reach childbearing years and thus passed on less the gene for hemophilia. The fact that hemophiliacs of today are having families, those genes are being passed on, and the incidence in Canada and the world shows us that carriers of hemophilia are on the increase. We are reminded that carriers of hemophilia may have normal or low factor 8 and 9 levels, but they can also have low levels, and symptomatic levels, or patients could have symptoms at levels of 5 to 60%. As a quote, factor levels betray but do not define hemophilia carriers. So patients with somewhat normal levels may bleed, and patients with lower levels cannot bleed. New nomenclature to define hemophilia in women and girls has been published recently to underline and underscore the importance of patients getting proper care when they need it, when their factor levels are low, or if they have bleeding problems clinically. The importance of carrier identification when it comes to delivery is the fact that there is to ensure adequate management of the delivery. So what's the impact of having unaware carriership? Basically is the fact that you would want to be prepared for the delivery and offer the safest mode of delivery possible. So if you are aware that the woman is a carrier, you can see that there is much less instrumental delivery that would occur. So forceps and ventouses would be much less used. You would also probably go much less to spontaneous vaginal delivery, and opt for more cesarean section if you knew that the fetus was affected. So the clinical decisions around knowing whether the baby, whether the mother is affected, and also whether knowing the baby impact clinical care on a daily basis. So what's the importance of carrier identification in terms of the risk of neonatal hemorrhage? Well, we know that there's an increased risk of intracranial hemorrhage following vaginal, instrumental, and vaginal delivery, with a relative risk of 6.96 and confidence intervals that go as high as 18. Other relative risks are as high as 17 and 12 in various studies. There's also pregnancy-related bleeding. Antepartum hemorrhage in carriers of hemophilia, there's no consistent data that tells us whether these patients are at risk for bleeding in the antenatal period. Compared to von Willebrand, where there's very little in the antenatal period, rare bleeding disorders in general may suffer from increased antepartum hemorrhage. The question is whether carriers have antepartum hemorrhage more than the general population. But we do know that patients are at risk for bleeding from invasive diagnostic tests, spontaneous abortion, or termination. And that's especially true in factor IX deficient carriers, where the factor IX may have not, or typically does not increase in pregnancy, or the factor VIII, which typically increases late in pregnancy and not in the first and second trimesters, where many of these techniques are being done, in which case the patient may not be protected from a hemorrhage point of view. And we know that patients that are carriers are all at risk of increased postpartum hemorrhage. So all of this information of identifying carriers and knowing if the fetus is at risk really has impact not only on maternal concerns and decisions around the delivery, but also around the care of the neonate. I think it's also important to identify carriers to be able to start the journey with them and help early in the discussions to make decisions about becoming pregnant, whether to have children or not. And of course, all of that will be influenced by experience with hemophilia that they've had in their personal families, if hemophilia has been running genetically. In addition, patients that would opt for pregnancy could benefit from genetic counseling. Prenatal diagnosis is very beneficial, again, for decisions around the obstetrical care, and also just from an emotional point of view, to be able to prepare mentally for having a possibility of increased bleeding or a baby that may be affected with a bleeding disorder. Also, it can be very distressing to think about antenatal diagnosis, and these patients need to be met on several occasions ahead of time. As I said, a journey starts at the beginning of pregnancy and even before so. There is invasive and early non-invasive testing that can be offered to patients. And again, these discussions require not only a hematologist, but a specialized clinic with expertise in carriers and often the input of a geneticist. And again, all of this together as a team would enable the woman to make informed reproductive decisions. So there are 3 tests that can be done to make prenatal diagnosis. The invasive tests include CVS, or chorionic villus sampling, and amniocentesis, and the non-invasive test is ultrasound and DNA testing. CVS is performed at 10 to 14 weeks typically. It permits early diagnosis and therefore early termination if desired by the family. And the risk of miscarriage in experienced hands is quoted to be at 1%, and from personal experience in groups and hospitals where it's done even more so, that risk is actually lower than 1%. Amniocentesis is performed after 15 weeks. It provides a later diagnosis, but there's less risk of miscarriage. Another option is if there's no concern about doing an early amnio or an early diagnostics because the patient is not going to terminate the pregnancy, even with the knowledge that she's carrying a baby with hemophilia. She may consider third trimester amnio if it's a male fetus, which is most reliable when performed after 16 weeks. This decision can help her decide whether she would opt for an elective cesarean section or a trial of vaginal delivery. There is also new diagnostics to allow fetal DNA in maternal circulation. With current technology, it has a virtual 100% sensitivity and specificity. It's obviously non-invasive. And what it does is it specifically looks at detection of the Y chromosome in the DNA sequence. And so you're able to identify whether it's a male baby or not. So these are all the choices that need to be discussed with carriers early on and again along the journey. The prenatal diagnosis using DNA requires a maternal blood sample. It's as easy as that. It determines fetal sex as early as 6 weeks. It can have some setbacks in terms of having a discrepancy to distinguish maternal and fetal mutations, and a specific assay is necessary for each mutation. It's typically done with real-time PCR. There are over 1,000 different mutations, but 50% of cases with severe hemophilia are caused by intron 22. So a specific assay targeting this mutation is highly beneficial, and especially if it's known in the family. So the take-home message, the first one, is that identification of carriers is important and should preferably occur prior to pregnancy, and knowing carrier status as well as the sex of the fetus is important, and it allows us to take the decisions that we need to in order to safely deliver a baby who is potentially affected with hemophilia. It also directly impacts the care we offer to the mother and directly influences the obstetric and newborn care. This is an algorithm that's part of the publication that was directed by Dr. Moorhead, which I had the privilege of taking part in along with Dr. Vicky Price. It basically takes us through the algorithm of whether the patient is identified as a carrier, whether a mutation is detected in the fetus, and offers discussion about the best way to manage the delivery. The management of delivery definitely requires advanced planning. In most institutions that are affiliated, that were multidisciplinary clinics that take care of women that are affiliated with hemophilia treatment centers, and even in those that are not affiliated with hemophilia treatment centers, one of the best ways to manage delivery is to have a prepared written delivery plan that should include information on obstetric care for the mom, planned mode of delivery, immediate postnatal care of the newborn. The delivery plan in general should be made very available because typically, as we all know, patients tend to deliver in the middle of the night on a weekend. And the best way to circumvent any problems is to have the delivery plan clearly typed out, ideally not handwritten, and available to both the parents, the multidisciplinary team, and ideally in some sort of electronic file that can be accessed at any time of the day or night. The question that's very controversial is what is the optimal mode of delivery? And the reason we ask this question is because we know that hemophilia carriers are at risk for neonatal intracranial hemorrhage. So if you actually look at hemophilia numbers, and these are whether carrier status is known or not, it seems that the babies that are affected with hemophilia have a much higher risk of intracranial hemorrhage than the normal population. I think this is clear in the numbers. So that's the first point. The other point is that it seems that the vaginal instrumentation, as you can see, increases the risk of intracranial hemorrhage in babies with hemophilia and gives a number of around 10%, which is unacceptably high, compared to in all deliveries as a mean or a median as 2 to 4%. C-section seems to confer a certain advantage and protection, decreasing that risk to 2.5%. And a vaginal delivery without instrumentation, in some studies, actually gives the lowest risk of intracranial hemorrhage. However, elective C-section also decreases the number of cases of intracranial hemorrhage down to 1.6%. So there is still controversy about whether vaginal delivery without instrumentation or elective C-section should be done for patients known to have male babies with hemophilia. There's a common risk factor, though, is that patients that have prolonged or abnormal labor are associated with increased risks of having intracranial hemorrhage in their hemophiliac offspring. And so one of the take-home messages is to avoid prolonged labor and to convert to early C-section if need be, if the labor is not progressing normally and a vaginal delivery is already planned. I would say that what's changed in the course of Canadian discussions and in the literature is that more and more we offer elective C-sections to the patient, describe the options, and I would say that over the last decade the pendulum is swinging a little bit more in favor of offering elective C-sections to patients who have male fetuses known to be affected with hemophilia. And that's a big change over the last 2 decades. So the optimal mode of delivery pro-C-section is basically a position that Canadians have veered towards over time. I know in the United States this has been a position that's been of long date. There are valid arguments for cesarean, including that it's difficult to predict when a woman's undergoing a planned vaginal delivery, and she may ultimately require an operative vaginal delivery or emergency C-section. And this is a type of situation where we want to avoid, knowing that an emergency C-section confers a very high risk of intracranial hemorrhage in the neonates affected with hemophilia. Once the baby head's engaged in the pelvis, a C-section becomes difficult, and our colleagues and obstetricians tell us that this is often past the point of no return, and operative vaginal delivery is most expeditious. In that case, sometimes earlier, they need to convert to an emergency C-section, and both of these situations are not what we want to see. So it's difficult to predict with a planned vaginal delivery when it might become operative in a way. And again, these situations are to be avoided. So in general, we like to discuss whether the patient is a good candidate or not for a vaginal delivery safely. Discuss with the patient the pros and cons of having a cesarean delivery, which is a surgery, and may confer bleeding risk to the mom. And if else fails and she's not a good candidate for a vaginal delivery, or if the risk conferred to her by having a C-section is not something that she wishes to embark on, a vaginal delivery can be planned with early conversion to C-section if the labor is not progressing according to plan. What's the risk of serious injury in the mothers? So it turns out that, of course, we have the notion that because cesarean is a surgery, that the risk of serious morbidity and mortality is much higher with cesarean section. But actually, you can see in this particular slide that the difference between the risk of serious morbidity and mortality for the mom between vaginal and cesarean section is actually not significantly different. The risk of postpartum hemorrhage is not either, nor is wound infection and systemic infection. So when you look at these arguments in favor, and a study coming out of the United States looking in favor of cesarean section, maybe we're a little too afraid to go straight to cesarean section in these patients. But again, the pendulum is swinging, at least in Canada, towards offering patients with hemophiliac babies to go to cesarean section. So in general, the optimal mode of delivery, if no obstetric contraindication, more and more we attempt a planned non-vaginal delivery. If instrumentation becomes a possibility, we convert to cesarean section. Planned cesarean section prior to labor does not prevent ICH versus a planned non-vaginal delivery. We should avoid fetal scalp electrodes and blood monitoring for the risk of causing a bleed in the head of the fetus. Consensus that there's no indication for cesareans in non-severe bleeding disorders. So here we're talking exclusively about severe hemophilia A and B. And in severe bleeding disorders, the safest mode of delivery should be assessed on an individual basis, but again, offering cesarean section up front should be now on the table. In terms of the postnatal care, we should avoid affecting the baby in a way that might cause the baby unnecessary bleeding. So in general, clinical assessment for bleeding includes intracranial hemorrhage, avoiding intramuscular injections, avoiding venipuncture as much as possible, and being very quick on the draw in case we feel that the baby is affected with an intracranial bleed. You manage as if the baby has hemophilia until the diagnosis is confirmed or ruled out. It's confirmed by a coag test done on usually on the cord blood, looking at PTT and factor 8 and factor 9 levels. There are age-related normal ranges that are published in tables that could serve as a reference. Genetic testing can be offered to the newborn, is usually unnecessary right away, and we can actually diagnose it based on factor 8 levels. For factor 9, it's often physiologically low, and that makes it a bit challenging to diagnose hemophilia B in a neonate. But we do send off genetic testing right away and get the results a little bit later. So routine newborn care includes vitamin K. We often suggest giving it subcutaneously, which does not confer a bleeding risk, rather than intramuscularly. We use a local vaccination schedule, and we tell patients to do a good compression of 10 to 15 minutes. We do routine newborn screening tests, like I mentioned, for factor levels and PTT, using a neonatal lancet and hold direct pressure for 5 minutes, sometimes 10 or 15. Use the smallest needle possible for venipunctures, and the idea is never to go to surgery without conferring with a pediatric or consulting with a pediatric hematologist, and certainly avoiding circumcision until the diagnostics are clear and hemophilia is ruled out. And if it's ruled in, to take the necessary measures to prevent bleeding at circumcision. Severe bleeding in the head requires immediate and aggressive management, and the question is which product to use. The aim is to aim at 100% to reduce in vivo recovery and increase clearance. Monitoring trough levels is required, and conferring with a hematologist for this is important. We monitor for inhibitor formation, and just keeping in mind that desmopressin is contraindicated in newborns with mild and moderate hemophilia. Avoid any invasive procedures in the neonate unless they have hemostatic coverage. And we would probably then offer short-term prophylaxis to limit the risk of intracranial hemorrhage, or at least discuss it, although this practice is heavily debated. Finally, the evidence for implantation of target or universal screening in newborns is not supported to do routine neuroimaging. We reserve neuroimaging only in the case an intracranial hemorrhage is suspected, and this can be by use of ultrasound, which are often the most easily available. These are some of the current research projects that are available, that are ongoing, including the CHIC-P study looking at the pathophysiology of postpartum hemorrhage in carriers of hemophilia A and B, the CHIMP study, which was the basis of this guideline, and others that are taking place in Canada to assess good practice in carriers of hemophilia and their offspring. So in conclusion, management of pregnancy, labor, and delivery requires a large multidisciplinary team. The discussions are delicate and require, as I said, a discussion before pregnancy and throughout the pregnancy, step by step, at every step of the way. The care should be coordinated through a hemophilia treatment center, either on-site or at a distance. There should be a clear delivery plan. The mode of delivery should avoid instrumentation at the very least. If intensive factor replacement is required for the baby, we need to monitor for inhibitors, as the babies are at highest risk for developing inhibitors. And further research is needed to address the important knowledge gaps that remain in this area. Thank you very much.
So thank you, Rochelle, for stepping in so brilliantly at the last moment. I think it really underlines your expertise in this area. We're now going to have a few minutes for questions, and maybe, Len, I can get you to turn your camera on again and your mic. I've received some questions in the chat, and I actually have some questions of my own. So, Len, the first question is to you. One of the participants and I noted how late women with bleeding disorders are getting to see hematologists, and you underlined this in your talk. Do you know why this is? Is it an issue related to late referral? Is it waiting lists are too long for hematologists to see people? Do you have some sense about why hematologists are seeing these women so late?
Well, Sarah, it's a great question, and I think the answer to the question is all of the above. I think there's a number of barriers that have been put in front of women to seek diagnostic services. And I think the least of which is the availability of hematologists. I mean, I think that's probably not the real barrier here. I think the real barrier is entry into the healthcare system. And it's the recognition that bleeding in women is not normal. I think, if a boy has bleeding, we frequently, as pediatricians or primary care physicians, will evaluate that more aggressively than we might for a girl, because traditionally girls don't have bleeding disorders. They don't get hemophilia, as we heard from one of the patient speakers. And I think we need to change the way medical students are educated, the way interns and residents are trained, and we really need to do a better job of educating the general public about the importance of recognizing these bleeding symptoms. That's why I'm so excited about really supporting and moving aggressively with the self-BAT. I think that's a great tool for us to really empower people to seek a diagnosis and then give them the tools to find the right diagnostician.
So I agree completely, and I think that the self-BAT and other similar things are wonderful tools. So let's say a woman who is concerned that she has a bleeding disorder takes the self-BAT, gets a positive test. What should she do? What should she say to her primary health care provider to get them to pay attention?
Yeah, so I think this is something that we still need some work on. We need some better materials to educate and empower people who self-identify at risk to have a bleeding disorder on what they need to bring with them to their primary care provider, to their obstetrician, gynecologist, to the pediatrician, whatever it might be. And I think that the most important is you need to enter into a shared decision-making mode. We can't go in and encourage patients to be sort of that all-knowing and be telling the physician, because I know from past experiences that even when I try to tell another physician something, they immediately become defensive, that you're challenging their knowledge, their expertise. And I think when a patient does this, it's even more perceived more egregious. So we need to give the right words and the tools to the patient to empower them to educate their healthcare professional in a congenial and supportive way, but not accept anything less than the appropriate care that they deserve and need to have.
Right. Still work to be done.
Exactly.
The next question is for you, Rochelle. Thank you very much for stepping in. And the question really is, how do we manage this perinatal plan for so many of our patients who live remotely? It seems to be true that the more significant the bleeding disorder, the further the patient lives from the treatment center in Canada. And many of the women we care for truly live remotely in Canada. How do you manage these women during their pregnancies and at the time of delivery who live so far away from the hemophilia treatment center?
So I think one of the things we're going to hear about actually by Roshni Karkalni tomorrow is going to revolve a little bit about the use of telemedicine and how useful that has been to be able to make treatment plans with our patients. In general, the main facets of a good plan include dialogue. So dialogue can happen with telemedicine, and so this has been a major way to help plan safely delivering these patients. And so the dialogue with the consultants, with the geneticists, with obstetricians can all happen remotely. The main issue and the bug is often the fact that we want these patients to deliver in a center where there is some expertise, the expert lab in coagulation, and also a way to have a reserve of product and to be able to administer those products when we need them in a timely fashion. And so that requires a blood bank, and it often requires an internist or a hematologist. And so what we try to do is get them to even if it's not possible to deliver in a treatment center that's closest to them, a tertiary care center, we try to get them to the center that has the most expertise and has access to blood supply. And very often these plans can be made virtually.
Thank you. So my final question is actually for both of you, and that is the new nomenclature that Robert Sidonio talked about. How will we best employ this new nomenclature for women with bleeding disorders, women with hemophilia, in terms of moving their care forward? Len, do you want to answer that first?
Well, I think that, thanks. It's a great question. And I think the first step in doing this is to socialize the new terminology and then educate clinicians on the terminology, which is going to be critical. Anytime there's new terms or that are introduced, it creates some confusion. And we already have a group of healthcare professionals who are thoroughly confused about bleeding disorders in general. And they don't really understand the difference between hemophilia, von Willebrand disease, and factor 13 deficiency. So it's already confusing. It's a challenge for these healthcare professionals who may see one patient potentially in their entire career of 30 or 40 years of practice. So I do think that it's going to require education, starting at the grassroots in medical schools first, and then we need to give the tools to the people, what we're calling subject matter experts. We need to make our patients be experts in their own disease, give them the tools to help then educate. Through that mechanism, I think we have a much greater opportunity to educate healthcare professionals by enlisting the army of people who live with these disorders to promulgate the new terminology and that education.
Rochelle, do you want to add to that?
I couldn't have said that better myself. I do think that it's going to take time. We can let all of us be the advocates and pass the message. We can let the patients pass their own message. But I think in the end, it's going to simplify is what I'm going to say. Because I have hemophilia or I don't is a much easier thing than saying I'm a carrier, but I might bleed and I don't know, and I'm not going to get the treatment that I require as if I'm a hemophiliac. So I think in the short term, it's going to create confusion. In the long term, I think it's going to be beneficial for all parties concerned. It's going to be a woman who has the same disease as a man with the same disease.
Okay. Thank you. Thank you both for your contributions this morning. The talks have been outstanding, and I'm now going to pass the mic back to Karen.